Alright, so I'm Casey Mullen and I'm going to be quickly running through the multi-segmental rotation breakout. So with this, we're testing three different portions or segments. We're going to do the spine, we're going to do lower quarter external rotation, and then lower quarter internal rotation of the hip and tibia. So first and foremost, just to see if we need to rule out the spine or not, we're going to start with the seated trunk rotation test. So we'd have the patient just sit in a chair, move to the very end of the chair, put their arms up to the side, and we're just going to have them put their right foot over their left, and whichever foot is crossing over on top, we're going to turn that side just to take out the pelvis. So right foot over left, we're going to look to the right. Alrighty, and then with that, we would left over right, and then look to the left. So with this, as the doctor, you'd be looking to the AC joint just to see if they can get to that 50 degrees of rotation. If they pass this with flying colors, we can go ahead and move on to the lower quarter portion. However, if they're not quite getting that 50 degrees, we need to go ahead and check out the spine. So to check the spine, we're going to do what we did just with multi-segmental extension. We're going to test the T-spine first using the lumbar lock test. So hands and knees, go backwards. We're going to have the doctor always stands on the opposite side of the side that they're testing. So doctor over here on the right side, patient will put their left arm up, look up, and then look straight forward. The doctor then can do it passively, and we're wanting to see the patient get to at least 50 degrees. Passively, the doctor would be standing on this side, so my right side. They would loop their arm around mine and basically do a bicep curl to lift me up passively. And again, we want 50 degrees. To test the opposite side, the doctor would be on my left. I put my right arm, the patient would put their right arm on their back, look that way, and then look up. Again, we're looking for 50 degrees. And the patient would do that the doctor would do that passively for the patient. The doctor would just, again, loop their arm through the patient's arm and do a bicep curl up for me. And we're looking for 50 degrees. So with that, if the patient can't perform it actively or passively, get to that 50 degrees, we're thinking, okay, maybe a T-spine mobility issue. However, if they aren't able to do it actively, but they can do it passively, then we're thinking, okay, maybe it's more of a stability issue in the T-spine. Before we move on though, we are going to go ahead and test the lumbar spine using the pronon elbow. So essentially it's just the same thing, except you are throwing back those legs. So we'd have the patient, put their left arm to the lower back, doctor would be on the right side, patient look up, and we want to see 30 degrees. Then the doctor would do that passively, so again they'd loop their arm around the patient, stabilize the right side, and do a bicep curl for the patient. Test it bilaterally, we'd have the patient put their right arm on their low back, doctor would be on my left, have the patient look to the right and look up, looking for 30 degrees. Then again, we would do that passively, so the doctor would still be on my left side. They would loop their arm around the patient's right arm here and basically do a bicep curl up for the patient. And we want to see 30 degrees. Excuse me. So after we rule in or rule out the T-spine, so if they pass out with flying colors, we still need to go on and look in the lower quarter. So first we're going to test lower quarter of external rotation. So a few different things here. We're looking for external rotation of the hip and the tibia. So the first thing that we're going to do is a active prone external rotation of the hip. So the patient will be on their stomach, face down. The doctor will bring up one of their legs. So this is going to be kind of difficult to show, but the doctor will bring up one of their legs and stabilize their pelvis. And while they're stabilizing the pelvis, the doctor will let go of the foot, 90 degrees, and we're going to have the patient just externally rotate, so drop it in. And we want to see them get to at least 40 degrees here. So if we're unsure, if they're not able to get to that 40 degrees, or if they are, we want to make sure that it's not a core stabilization issue, or maybe like an acetabular hip mobility issue. So with that, we're going to do a stabilized prone active hip external rotation test. So same thing, patient prone, except the patient's going to grab both sides of the table underneath it, and that way they can activate their core throughout this movement. So again, the doctor will bring up the patient's leg to 90 degrees while they're still holding on. Doctor still stabilizing the pelvis. And then we are just going to let go again and have the patient externally rotate the hip. So if we're unsure what's going on here, we are going to go ahead and do this passively, so that way we can compare active versus passive hip external rotation to make sure it's not core stabilization or if it actually is a true hip mobility issue. So for passive, again, for hip external rotation, we are going to have the patient lay prone still. Relax these, we're not utilizing that core anymore. Doctor's gonna bring the knee to 90 degrees and then let go, not let go. The doctor will take the patient's foot and bring it in passively for external rotation. Alright, so if they can't do that passive or active, then we're thinking, okay, maybe they do have some issues in their hip with external rotation. We do want to go on to test the tibia's external rotation still. So with this, we'd have the patient get up, get in a chair, scoot to the edge of the chair, kind of relax here. And we're just going to have them externally rotate each one of their feet. So externally rotate, they're bringing it out. And we want to see them get to 20 degrees. I know in the SFMA online portion, they say they would like to see 40 degrees, but by the book, 20 degrees at least. So just have them externally rotate each foot and try not to bring their knees out, so just the foot. If we're unsure if they're actually getting that 20 degrees, we can go ahead and do this passively as well. So the passive tibia external rotation, we'd have the patient come to their back. The doctor would bring one of their knees up to about 90 degrees, and they would push in here and just externally rotate the foot for the patient. And you can do that on both sides. So the doctor would grab the foot and just externally rotate it. And again, we want to see that 20 degrees. So next we would test lower quarter internal rotation of the hip and the tibia. So first and foremost, to test the hip, we're going to again do the active prone hip internal rotation test. So this is all the same, except we're going internally rotate the hip instead of externally like we just did. So patient's prone. The doctor's going to stabilize the pelvis, bring the patient's foot to 90 degrees or knee to 90 degrees, and then they're going to drop it and see how far it goes for internal rotation. So it should come outwards, so towards the doctor. And we want to see this get to at least 30 degrees. To make sure, again, if it's not hip acetabular issue versus a core stabilization, we're going to do a stabilized, active, prone hip internal rotation test. So have the patient still prone, have them grab both sides of the table to activate their core. Again, the doctor's going to bring their knee to 90 degrees, and then they're going to drop it and let it internally rotate to see if it goes further or stays up straight with that core activation. To make sure it's actually a mobility issue of the hip for internal rotation, we're going to go ahead and test it passively as well. So a passive prone hip internal rotation test. Patient prone. Relax those arms. The doctor's going to bring the knee up to 90 degrees and then passively bring it out. And again, we want to see 30 degrees here. And that way we can know if it's a stability issue or if it actually is a true hip mobility issue. We still want to go ahead and go on to test the tibia's internal rotation. So we'd have the patient get up, sit in a chair, come to the edge. We want to make sure when they're bringing their feet internally that we don't have any knees coming in or knee bobbing. So if these are my feet, which is kind of hard to see, we'd have them just internally rotate one at a time. And we want to see again 20 degrees. Do that on both sides. If we're unsure if they're getting that 20 degrees or it's just kind of hard to eye, we can do this passively. So a passive tibia internal rotation, have them on their back. The doctor's going to bring their knee up to 90 degrees. They're going to grab the patient's foot and internally rotate it for them. So internally, internally. And they do that on both sides to see if they get 20 degrees. And that is the entire multi-segmental rotation. Thank you.